Chapter 5, the skeletal system. So you can see on this slide, I was going to list your learning objectives, but they can be found throughout your text chapter. There was too many to list here. If you think about the skeletal system, there's actually 206 bones in the adult skeleton, so just try to apply that to your learning objectives. As I said, they can be found within your text or in your ebook. First, let's talk about a few of the functions of bones. So here are 5 listed functions. You should know at least 3, and I think most of them will be obvious to you. So things like support. Your skeleton is the steel frame of the body. It provides a framework, an internal framework for the body, cradling the soft organs. It's how you stand upright. It also offers protection. It protects your soft organs. The example here on the slide is how the skull covers your brain to protect it, but also how your ribs protect your lungs, or your pelvis protects your reproductive organs, or how your spinal column, the vertebrae of your spinal column, protect your spinal cord. It also allows movement. So skeletal muscles are attached to the bones via tendons, and the bones act as levers to move the parts of your body. This is how you can breathe. This is how you can walk. This is how you can swim. It also provides storage. So fat is stored in the marrow of your bone, so the center of your bone. And minerals like calcium are stored in the bone, the hard bone material itself. Blood cell formation. So blood cell formation is called hematopoiesis, and it occurs in the marrow of certain bones. So this is an important function in your body. Bones can be classified a few different ways, and one of the ways is based on how they look. So we have compact versus spongy. So compact bone, you can see in the image, is that outer white and just the inner white, that dense, smooth, homogeneous, meaning that it all looks the same. And then the spongy in the middle there, you can see it looks like a sponge. It's spiky, parts of it are open, it is not homogeneous, it doesn't all look the same, and it's spongy. Bones are also classified by their shape. So we have long bones. Just like it sounds, they're longer than they are wide. They generally have that middle shaft with enlarged ends. So think of like a chicken drumstick bone. Mostly compact bone, but always also contains spongy ends. And then all of the bones of the limbs, except for your patella at the front of your knee, your wrist bones, and your ankle bones, are long bones. Then flat bones. So these are thin, flattened, usually curved, 2 thin layers of compact bone sandwiching spongy bone. So this would be found in the bones of your skull, in the ribs, and in the sternum. Short bones. So generally cube-shaped and contain mostly spongy bone with an outer layer of compact bone. So this would be the little bones in your wrist, the little bones in your ankles, sesamoid bones, which form with tendons. An example of that is your patella. And then irregular bones, basically anything that doesn't fit into one of these 3 categories. So mainly spongy with an outer layer of compact bone. An example of this would be your vertebrae. So they're not shaped like any of the other classifications of bone shapes, but you'll notice that common among all types, we have that compact bone on the outside and spongy on the inside or in the middle. And here's just an image displaying some examples of some of those bones. So you have your humerus bone. Here in image A, it's a long bone. So your humerus is, you can see it's that top bone of your arm, kind of why we call the elbow the funny bone. It's humerus. B is your sternum. It's right in the center of your chest, and that's a flat bone. So again, it has those 2 layers of compact bone sandwiching spongy bone. C, your talus, coming out of your Foot ankle area, it's small, kind of cube shaped, mostly spongy, but still with that layer of compact bone. And then D is that irregular bone, that vertebrae like I was talking about. And this is just your right lateral view. But you can see that it's irregularly shaped, but again, has that compact bone with the spongy bone in the center. The gross anatomy of the long bone. So again, a long bone, example of a long bone would be your humerus. Basically, all of the larger bones in your appendages, so your upper extremities, lower extremities, your arms and your legs. So the diaphysis, otherwise known as the shaft, so the long part of your bone, makes up most of the bone's length and is composed of compact bone. It's covered and protected by a fibrous connective tissue membrane called the periosteum. Hundreds of connective tissue fibers called perforating fibers or Sharpie's fibers secure the periosteum to the underlying bone. It's like a tight jacket. And the epiphyses are the ends of the long bones. Each consists of a thin layer of compact bone enclosing an area of spongy bone. So instead of periosteum, articular cartilage covers the external surface. Because the articular cartilage is glassy, hyaline cartilage, it provides a smooth surface and that decreases friction at the joint when covered with lubricating fluid. So it's smoother, it's slicker, so it allows for better joint movement. So in this image, in A, it's the anterior view of the longitudinal section cutaway of a long bone. You can see there the diaphyses and the proximal and distal epiphyses, right? So proximal closer to the center of the body, distal closer to the end of the body or lower part of the body, or farther away from the center rather. And then you can see that hyaline cartilage at the end, that white hyaline cartilage, articular cartilage at the top and the bottom. B is that pie-shaped cutout, is just a three-dimensional view of the spongy bone and compact bone of the epiphyses. So you can see that it's a thin layer of that compact bone and all that sponge-like bone right at there at the end. And then in C, you can see a cross-section of the shaft or the diaphyses. And note that the external surface of the diaphyses is covered by a periosteum, but that the articular surface of the epiphyses seen in A and B is covered by the hyaline cartilage. So while it's all the same bone, that outside jacket it's wearing is different at the ends than it is in the middle. Talking more about those long bones. So we have something called an epiphyseal line, which is seen in adult bones, and an epiphyseal plate. So the epiphyseal line is a thin line of bony tissue spanning the epiphyses, so right, the ends of the long bone, that look a bit different from the rest of the bone in that area, and it's a remnant of this epiphyseal plate. The epiphyseal plate is a flat plate of hyaline cartilage seen in young growing bone, and it enables the bone to grow lengthwise as a person grows. So a growth plate. So by the end of puberty, when hormones inhibit that long bone growth, epiphyseal plates have become replaced by bone, leaving only epiphyseal lines to mark their previous location. So a couple other things you can see here, and see in your book rather. Endosteum is the inner bony surface of the shaft made of delicate connective tissue. The medullary cavity, it's the storage area for the red marrow, which produces blood cells. And then yellow marrow is where adipose tissue is stored. Medullary cavity is found in infants and remains in children until about the ages of 6 or 7, when it's replaced by yellow marrow. In adults, red marrow is confined to the cavities in the spongy bone of the axial skeleton, the hip bones, and the epiphyses of the long bones, such as the femur or the humerus. Here you can see a chart of different bone markings. projections that are sites of muscle and ligament attachment. You can see the name of them, the description, and then an illustration. But bone markings basically just reveal where muscles, tendons, and ligaments attach and where blood vessels and nerves pass. There's two categories. So we have projections or processes, right? So they stick out, they project, which grow out from the bone surface, or depressions or cavities, which are indentations. So the trick to remembering most of these is that anything that starts with a T is a projection, anything that starts with an F is a depression, except for facet. Facet is actually a projection. So under a microscope, spongy bone is composed of small needle-like pieces of bone called trabeculi and lots of open space filled by marrow, blood vessels, and nerves. You can see in this image, it shows a pie-shaped segment of compact and spongy bone showing their structural units. So the structural units of the compact bone are called osteons, and the structural units of the spongy bone are called trabeculi. In B, you can see a higher magnification view of one of those osteons, and then C is a cross-sectional view of an osteon as well. So in compact bones, mature bone cells are called osteocytes, and they can be found within the bone matrix in tiny cavities called lacunae, which are arranged in concentric circles called lamellae around central canals. Each complex consisting of a central canal and those matrix rings is called an osteon. So you can see that in the photos here. It almost looks like the center, a cross-sectional of a tree. It just has these concentric rings. Tiny canals called canaliculi radiate outward from the central canals of all lacunae, and it forms a transportation system that connects all the bone cells to the nutrient supply and waste removal services through the hard bone matrix. Because of this elaborate network of canals, bone cells are well nourished in spite of the hardness of the bone matrix, and bone injuries heal fairly quickly. Communication pathway from the outside of the bone to its interior is completed by perforating canals, which run in the compact bone at right angles to the shaft in central canals. So what's pretty cool is that bone is one of the hardest materials in the body, but it's also very light, which is what enables us to stand upright. So it also gives us the ability to resist tension and other forces acting on it. So if anybody lifts weight, that it's pretty nifty that your bones are so strong, but they're so light that you're able to make these good movements against force and apply this great tensile strength. And we'll talk about some of the other things that give just our skeletal system, you know, that flexibility of movement. Stages of long bone formation. So we can see here in this image, it goes from in an embryo to in a fetus to in a child. So in embryos, the skeleton is made up primarily of this hyaline cartilage that acts as a model for the bone. So it's the blueprint for the bone. So bone formation, also known as ossification, occurs and involves two major stages. First, this hyaline cartilage model or blueprint is completely covered with bone matrix, something called a bone collar, by bone building cells called osteoblasts. So as the embryo develops into a fetus, for a short period, it has cartilage bones just enclosed in a bone matrix. So it's just cartilage, basically bone dipped, like candy dipped in bone matrix. Then in the fetus, the enclosed hyaline cartilage model is replaced by bone, and that center is digested away, opening up that medullary cavity, which holds that red marrow, right, until they're 5 to 7, and it holds it within that newly formed bone. So by birth or shortly after, most hyaline cartilage models have been converted to bone except for two regions. So we have the articular cartilages that cover the bone ends and those epiphyseal plates. And in order for bones to increase in length as the infant grows into a child, new cartilage is formed continuously at that external surface of the articular cartilage and on the epiphyseal plate surface that faces the bone end. So you can see that demonstrated here in this photo. At the same time, the old cartilage abutting the internal surface of the articular cartilage and the medullary cavity is broken down and replaced by bone matrix. So all the while, bone is being added, and so as the bone grows, it's remodeled so that it still has the same structural integrity. Growing bones, it is important to note that growing bones will also widen as they lengthen to maintain proper proportion, and they widen by osteoblasts in the periosteum, adding bone matrix to the outside of the diaphyses, as cells called osteoclasts in the endosteum remove bone from the inner surface. So it's not that the diaphyses gets thicker, it's just that inside is getting thinner and outside is getting thicker, so it's kind of moving out. Because the two processes occur about the same rate, the circumference of the bone expands and the overall bone widens. This process by which bones increase in diameter is called oppositional growth, and like growth in length, it is controlled by hormones. In bone remodeling, we'll talk about bone remodeling a little bit on the next slide, actually. So bone remodeling, bones are dynamic and active. They are remodeled continually in response to calcium ion levels in the blood and the pull of gravity and muscle on the skeleton. So it's essential to retain normal proportions and strength during long bone growth. Bones become thicker and form large projections where bulky muscles are attached. Here, osteoblasts lay down new matrix and get trapped, becoming osteocytes, which are those mature bone cells. So you guys should recognize this feedback loop here, feedback mechanism. So blood calcium ion levels drop, stimulating the parathyroid glands to release parathyroid hormone, which activates osteoclasts, which are actually bone destroying cells, which break down that cell matrix and release calcium ions into the blood. And then if the calcium ion levels are too high, calcium is deposited into the bone matrix as hard calcium salts by osteoblasts. So osteoclasts break it down, osteoblasts builds it up. We'll talk briefly about bone fractures. So there's a couple different ways that they're classified. We have open versus closed. So all open versus closed means is that you fractured a bone and part of that bone is sticking outside of your skin. That's open. If nothing is sticking outside of your skin, it's closed. Most bone fractures, all bone fractures are treated by what's called reduction. So we have a closed reduction, which is like you broke your leg and they're going to numb you up and just push it back into place, which is pretty gnarly. Versus open reduction is when they have to cut you open. You know, they have to go in and place hardware or move the bones back into place and place hardware with either internal fixation, so that would be like your rods and your pins inside the body, or external fixation, which is rods and pins outside the body, which is pretty intense. Here this chart just shows you different kinds of fractures. So we have the comminuted fracture, that where bones break into 3 or more fragments. It's common in older people because their bones are weaker, they're more brittle. Compression fractures is when the bone is crushed. So common in porous bones, again, mostly osteoporotic bones, which generally will occur in older people. A depressed fracture would be broken bone portion that is pressed inward. Typical of a skull fracture, definitely not ideal. Impacted fracture is broken bone ends are forced into each other. Oof. Commonly occurs when someone attempts to break a fall with an outstretched arm. and spiral fracture. So I'll include in our class meeting a pretty cool x-ray of my fracture a few years ago. So I did have what looked like a pretty common spiral fracture. So it just looks like it broke in a spiral due to twisting forces. So it's common in sports fractures. And then green stick. So this is most common in children because their bones are a lot more flexible than adults, but the bones break incompletely. And even sometimes it's not, you can't even see this gap that it shows in this image. It's simply just a line in the bone. Let's talk about the stages of healing of a bone fracture. So this breaks it into 4 parts here. So first, the hematoma forms. So blood vessels are ruptured when the bone breaks. As a result, a blood-filled swelling or bruise called a hematoma forms, and bone cells deprived of nutrition die. And 2, fibrocartilage callus forms. So 2 early events of tissue repair are the growth of new capillaries of that granulation tissue into that clotted blood at the site of the damage, and then disposal of dead tissue by phagocytes. As this goes on, connective tissue cells of various types form internal and external masses of repair tissue, which collectively are called fibrocartilage callus. The internal and external masses called calluses originate from cells in the endosteum and periosteum respectively, and contain several elements to include cartilage matrix, bone matrix, and collagen fibers, which act to split the broken bone, closing the gap. The bony callus forms. So as more osteoblasts and osteoclasts migrate in the area and multiply, the fibrocartilage callus is gradually replaced by bony callus made of spongy bone, and then bone remodeling occurs over the next few weeks to months. So depending on the severity of the break, company line is usually takes about 6 weeks for a bone to fully heal. The bony callus is remodeled in response to mechanical stresses placed on it so that it forms strong permanent patch at the fracture site. So you can see, depending on how quickly you're able to reduce a fracture, you know, it can't be days or weeks before a fracture is reduced, or in other words, the bones are put back into place, because this process is going to continue whether your bone is aligned or not, right? You're going to form this fibrocartilage callus, you're going to form this bony callus, and then your bone might heal incorrectly. And especially in children that are still growing, this could cause a lot of problems. The skeleton is broken down into 2 parts. So we have the axial skeleton and the appendicular skeleton. So here in this image, you can see the axial skeleton is that green, that light green color, and the appendicular skeleton is that gold color. So the axial skeleton forms the longitudinal axis, that long axis of the body, and can be divided into 3 parts: your skull, your vertebral column, and the thoracic cage. And an easy way to remember appendicular is that this is the part of your skeleton that the appendages, your arms and legs, are a part of. So the top part of the superior part of your axial skeleton is your skull. It's formed by 2 sets of bones. The cranium encloses and protects your nice, soft, fragile brain, and the facial bones form a cradle for the eyes that are open to the anterior and allow the facial muscles to show our feelings. So you can see this image here, a full list of all the different parts of the skull. We'll talk more about them on the next slide. So the skull is formed by 2 sets of bones, as we discussed. The box-like cranium is composed of 8 large flat bones, except 2 of them are sets. 2 of them are a pair, and this is going to be your paired parietal and your paired temporal. Otherwise, they're all single bones. So we have the frontal bone, which is, you know, not tricky. It's right at the front of your head. It forms your forehead, the bony projections under the eyebrows, and the superior parts of the eye orbit. The parietal bones form the most superior and lateral walls of the cranium. You can see this in the figure as well. The sagittal suture is formed at the midline where the two parietal bones meet, and the coronal suture is formed where the paired parietal bones meet the frontal bone. So this is better seen on the previous slide in that picture view, but I encourage you to oscillate back and forth so you can see both of those photos. The temporal bones lie inferior to the parietal bones and join them at the squamous sutures, again seen better on the previous image. And there are several important bone markings on the temporal bone. So we have the external acoustic meatus. So this is the canal that leads to your eardrum in the middle ear. And it's how you hear things. The styloid process, sharp needle projection, just inferior to the external auditory meatus. Many neck muscles use the styloid process as an attachment point, which you can see in this image. The zygomatic process is a thin bridge of bone that joins the cheekbones anteriorly. The mastoid process, which is full of air cavities, the mastoid sinuses, is a rough projection posterior and inferior to the external acoustic meatus. It provides an attachment site for some of the muscles in the neck. The mastoid sinuses are really close to the middle ear, and it's a really high risk spot for infections. And they may become infected too if somebody gets an ear infection called mastoiditis. And this area is also close to the brain, so an infection in the mastoid sinuses could lead to an infection in the brain. The jugular foramen is at the junction of the occipital and temporal bones, and it allows the passage of the jugular vein. So that's pretty important, which is because it's the largest vein in the head and it drains blood from the brain. Just anterior to the cranial cavity is the internal acoustic meatus, which transmits cranial nerves 7 and 8, the facial and vestibular coccylar nerves. Anterior to the jugular foramen is the skull's inferior aspect. On the skull's inferior aspect is the carotid canal. So this is where your internal carotid artery runs, which supplies your oxygenated blood to most of the brain. The occipital bone. So this one can be found at the back of the skull. This is the most posterior bone. It forms the base and back. Joins the parietal bones anteriorly at the lambdoid suture, and in the base of the occipital bone is a large opening, the foramen magnum. So it literally means a large hole, and it surrounds the lower part of the brain and allows the spinal cord to connect with the brain. Lateral to the foramen magnum on each side are the rocker-like occipital condyles, which rest on the first vertebrae of the spinal column. So you can kind of see in this image on the left, that bright pink posterior to the eyeballs, we have the sphenoid bone. It's kind of butterfly shaped, and it spans the whole width of the skull and forms part of the floor of the cranial cavity. In the midline is a small depression called the sella turcica, or Turk's saddle, which forms a snug enclosure for the pituitary gland. So this is where your pituitary gland is located. The foramen ovale, a large oval opening in the line of the posterior end of the sella turcica, allows fibers of cranial nerve 5, the trigeminal nerve, to pass to the chewing muscles of the lower jaw, also called the mandible, which you can also see in the photo. Parts of the sphenoid bone seen exteriorly form part of the eye orbits, which is why I can see them through the eye sockets. And they have two important openings: the optic canal, which allows the optic nerve to pass to the eye, and the slit-like superior orbital fissure, through which cranial nerves controlling eye movement 3, 4, and 6 pass. There's a lot of air cavities here, and these are your sphenoidal sinuses, which you can see in the photo on the right. Ethmoid bone is very irregularly shaped, And you can also see that little guy. It appears in this picture on the left as orange. It lies anterior to the sphenoid, and it forms the roof of the nasal cavity and part of the medial walls of the orbits. Projecting from its superior surface, so from the top, is the crystal gale. The outermost covering of the brain attaches to this projection. On each side of the crystal gale are many small holes called cribriform plates, and it allows nerve fibers carrying impulses from the smell receptors, the olfactory receptors of the nose to the brain, and extensions of the ethmoid bone, the superior nasal conchae, and the middle nasal conchae form part of the lateral walls of the nasal cavity. So from this front view, you can see a lot of the facial bones. So the facial bones it's made up of 14 different bones. 12 are paired, and only the mandible down here at the bottom, the bright red, your jaw, and the vomer are single. So the vomer is here as well at the top, in the center of your face. So the maxillae or maxillary bones, in purple here, form to fuse your upper jaw. So all facial bones except the mandible join the maxillae. They're noted as the keystone bones of the face. They carry the upper teeth. Extensions of the maxillae are called the palatine processes, and they form the anterior part of the hard palate of the mouth. Like many other facial bones, the maxillary sinuses, they contain sinuses which drain into the nasal passages, and paranasal sinuses reveals the position surrounding the nasal cavity. They lighten the skull bones and amplify sound as we speak. Palatine bones, paired bones that lie posterior to the palatine processes of the maxillae. They form the posterior part of the hard palate, as I mentioned, and failure of them to fuse is what causes cleft palate, that opening in the top of the mouth. Zygomatic bones, these are your cheekbones. This is how some people will have more prominent ones, but they also form a good-sized portion of the lateral walls of the orbits, which is important to hold your eyeballs in place. Lacrimal bones, small bones about fingernail sized that form part of the medial wall of each orbit, and each of them has a groove that serves as a passageway for your tears. Lacrima means tear. Nasal bones, small rectangular bones forming the bridge of the nose. These are the nasal bones. The lower part of the skeleton of the nose is made up of cartilage. So if you touch the end of your nose, it's all bendy and soft, it's cartilage. And the vomer bone, again, that the only other single bone other than the mandible, is at the median line of the nasal cavity. So here it's, it looks like it's bright blue. It means plow, which refers to the bone's shape. It forms the inferior part of the bony nasal septum, which separates your nostrils. The inferior nasal conchae, thin curved bones projecting medially from the lateral walls of the nasal cavity. And then the mandible is at your lower jaw, so it's the strongest bone in your face. It joins the temporal bones on each side of the face, and it's the only freely moving bone and the only freely movable joints in the skull. You can find these joints by yourself by placing your fingers just anterior to your ears and opening and closing your mouth. So this is when you'll hear a lot of people say, I have TMJ, temporomandibular joint. Most people mean that they have TMJ syndrome, where it gets tight, it gets locked up. Everybody has a TMJ. I tease a lot of my friends about this because people will be like, oh, I have TMJ, I can't chew gum. Well, we all have TMJ. You mean you have TMJ syndrome. And you can see again on the right here where all of these sinuses lie, and these are just air cavities created by the bones. Let's talk about the hyoid bone. So it's not really part of the skull, but it is closely related to the mandible and temporal bones. So it's unique that it's the only bone of the body that does not articulate, which means it does not form a joint with another bone. Instead, it's suspended mid-neck, about 1 inch above your larynx, which is your voice box, and it's anchored by ligaments to the styloid processes of the temporal bones. You can see here it's horseshoe shaped, with the body being the main part of it, a lesser horn and a greater horn, and it serves as a movable base for the tongue and as an attachment point for neck muscles that raise and lower the larynx when we speak. This is also often a bone that can be assessed in cases of strangulation or potential strangulation, because oftentimes it'll be fractured. Let's move on to the vertebral column, also known, more commonly known as the spine. You can see in the image on the left, it's showing you anterior and posterior. We have the cervical vertebra. There's 7 cervical vertebrae, 12 thoracic, so that about your mid to end of your shoulder blades, down the majority of your back, and then your lumbar, which is 5. And down here at the end we have the sacrum and the coccyx. So the book has you remember them a pretty good way. The way you can remember how many of each of cervical, thoracic, and lumbar there are is just by remembering common meal times. So you eat breakfast at 7 a.m., lunch at noon, dinner at 5, 7, 12, and 5. So your spinal column will extend all the way from the skull down to your pelvis. Before birth, it consists of 33 separate bones, and then down here at the bottom, 9 of them or so will fuse to become the sacrum and the coccyx. I say spinal column, it is not your spinal cord. Your spinal cord is what runs through it, and it's part of your nervous system, but your vertebral column is what protects it. In general, the vertebral column is made up of 26 irregular bones. Remember the type of bones classified by shape, connected and reinforced by ligaments in such a way that makes it curved and flexible. Obviously, there are certain homeostatic imbalances related to spinal curvature, things like scoliosis or kyphosis, lordosis, which we'll talk about in our lecture in our Zoom class, but it needs to have some flexibility in order to enable us to have mobility. Let's talk a little bit more about the structure, the vertebrae. So it's a single vertebrae, and you can see here the body is the majority of it. It's this disc-like, and you can see there's spongy bone in there. The weight-bearing part is anterior in the vertebral column. Vertebral arch is the arch formed from the joining of all posterior extensions. So that's outlined in the back here in a rainbow shape. The vertebral foramen is the canal through which the spinal cord passes, so the hole where the spinal cord goes. So you can see it's kind of central between the anterior and the posterior aspects. Transverse processes, there's the 2 lateral projections from the vertebral arch itself. The spinous process is a single projection arising from the posterior aspect of the vertebral arch. So you can see that at the back. the posterior aspect of the vertebrae. Superior or inferior articular processes are paired projections lateral to the vertebral foramen, allowing the vertebrae to form joints with the adjacent vertebrae. So it's kind of like Lincoln logs, or, you know, blocks that fit just so. That's what that articular process does. It just allows it to fit together. There are some slight differences depending on the location of the vertebra in the spinal column, so we'll take a look at those on the next slide. So we can see in A, the atlas has no body. So this is the first two vertebrae, the atlas and the axis of the cervical spinal region, are different because they perform functions not shared by other cervical vertebrae. So the superior surfaces of its transverse processes contain large depressions that receive the occipital condyles of the skull, right? The skull is resting on the first vertebrae of the neck. And then the joint allows you to nod yes. The axis, which is still in A, but C2, acts as a pivot for the rotation of the atlas and skull above. So it has the large upright processes, the dens, which act as a pivot point. So these are what allow you to rotate your head, to shake it, say no. Do you want more work in this class? And you shake your head no. That's what allows you to do that, the atlas and the axis. The typical cervical vertebra can be seen in B in the top right. They're the smallest and lightest vertebrae, and most often their spinous processes are short and divided into two branches. The transverse processes of the cervical vertebrae contain foramina, so openings, through which the vertebral arteries pass on their way to the brain above. So this is also pretty important. Anytime you see these foramina in the vertebrae, you know immediately that it is a cervical vertebrae. So that's how you can differentiate them from the other vertebrae. And that's just in that top right, the holes on either side of the body. In C, you can see the thoracic vertebrae, the bottom left image. They're all typical to the one that I just showed you on the previous page. They're larger than the cervical vertebrae and distinguished by the fact that they only articulate with the ribs. They're the only vertebrae out of all the different types that articulate with the ribs. The body is somewhat heart-shaped and has two costal facets, so articulating surfaces on each side, and that's where the heads of the ribs sit. The transverse processes articulate with the knob-like tubercles of the ribs, and the spinous process is long and hooks sharply downward, causing the vertebra to look like a giraffe's head viewed from the side. So that's that bottom of that left image, that right lateral view. Yeah, I can kind of see it. The processes are the ears, the spinous process is the neck, and the body is the face. Or vice versa, the spinous process is the face and the body is the neck. So let's look at the lumbar vertebrae in D. So there are, again, 5 of these. They're massive, block-like bodies, are shaped somewhat like a kidney bean. And their short hatchet-shaped spinous processes make them look like a moose head from the lateral aspect, which you can see on the bottom. Yeah, I can kind of see that too. Because most of the stress of the vertebral column occurs in the lumbar region, these are the sturdiest of the vertebrae, right? This is where a lot of people feel, stress on their bodies if they're working out, just stress in general, and it's built to hold more load than the rest of the vertebrae. So in the image on the right here, we're looking at the sacrum and the coccyx. The sacrum is 5 fused vertebrae, and the coccyx is the fusion of 3 to 5. You can see or surmise that the sacrum articulates with the bottom vertebrae of the lumbar spine, so L5. Each wing-like ala articulates laterally to the hip bone. So sacroiliac joint forms the posterior wall of the pelvis. So it is, has protective properties too. And then the coccyx, just at the little bottom, it's your tailbone. And it's the remnant of the tail that other vertebrate animals have. So location-wise, you can see if somebody falls right on their bottom or straight down from standing onto their bottom, they're at risk for fracturing their coccyx. Now let's talk about the thoracic cage. So the bony thorax is made up of the sternum, ribs, and the thoracic vertebrae, which we just talked about on the last slide. The bony thorax is often called the thoracic cage because it forms that protective cage of bones and cartilage around the organs of the thoracic cavity. So that would be your heart, your lungs, and a lot of major blood vessels. First, the sternum. You can see right here in the center. You can touch it on your own body and feel it. It's a typical flat bone, and it's the result of the fusion of three bones. So the manubrium, body, and xiphoid process. So we can see that in the image here. The body is the main part, or the largest part of the sternum. The manubrium is at the top. So again, you can palpate that on yourself. And then the xiphoid process is right at the bottom. It's attached directly to the first 7 pairs of ribs, which you can count on here too. The sternum has 3 important bony landmarks: the jugular notch, the sternal angle, and the xiphisternal joint. So jugular notch, the concave upper border of the manubrium, so it's right at the top. Some people have a more defined one that you can see on their body, but you can also just palpate it. It's easily palpated. The sternal angle is where the manubrium and the body meet at a slight angle to each other, so that a transverse ridge is formed at the level of the second rib. It provides a handy reference point for counting ribs to locate the second intercostal space, which is, some of you may know, some of you will learn wherever you're going to listen to certain heart sounds. And to clarify the location of these structures, you can palpate your own sternal angle. So go ahead and practice doing that. You can feel your jugular notch and palpate down till the sternal angle. The xiphisternal joint is the point where the sternal body and xiphoid process fuse. So that's going to be closer to the bottom, and it lies at the level of the 9th thoracic vertebrae. Because the sternum is so close to the surface of the body, it's easy to obtain samples from its blood-forming tissue for the diagnosis of suspected blood diseases. So in that case, they would just insert a needle to take out marrow from the sternum, and it's called a sternal puncture. However, because a very important organ lies very close beneath that, your heart, and your lungs for that matter, it is done under extreme care. So there are 12 pairs of ribs that form the walls of the bony thorax. All of the ribs will articulate with the vertebral column posteriorly and then curve downward and towards the anterior body surface. The true ribs, quote unquote true ribs, are those first 7 pairs that connect to the sternum. And the false ribs, the next 5 pairs, either attach indirectly to the sternum or aren't attached to the sternum at all. So the last 2 pairs of false ribs lack sternal attachments, so they're called floating ribs. So you can see that all in this image as well. And then the intercostal spaces is just the spaces between the ribs, filled with intercostal muscles, and they aid you in breathing. In this image as well, in B, you could see this cross section of the jugular notch, the sternal angle, the heart. It's pretty cool, and the xiphisternal joint. So the right side of the image is the anterior aspect of the body, and the left side of the image is the posterior aspect. This person looks very, very thin, or crushed, because that's all. We're also looking at the spinal column posteriorly on that left side of image B. Now let's start talking about the appendicular skeleton, right? Remember, appendicular is appendages, so this is going to be your arm, your limbs, right? So the bones of the shoulder girdle, aka the pectoral girdle, right? Paired clavicles are your collarbones, which you can palpate on yourself as well. Each clavicle attaches to the manubrium of the sternum medially, so right where that jugular notches that we just palpated on ourselves, it's going to attach very close to that area. Paired scapulae, your shoulder blades. The glenoid cavity is the shallow socket that receives the head of the arm bone, and the acromion process is the enlarged lateral end of the spine of the scapula. Coracoid process points laterally over the top of the shoulder and anchors some of the arm muscles. And the suprascapular notch medial to the coracoid process serves as a nerve passageway. So the clavicle acts as a brace to hold the arm away from the top of the thorax and help prevent shoulder dislocation. So when it's like a kickstand for your shoulder and your upper arm. So when your clavicle fractures, oftentimes the whole region will cave in. So if you see people standing, I don't know if anybody here has ever fractured a clavicle. A lot of times their shoulder will fall in medially towards the middle of their body. Your shoulder blades are often called wings. They're not directly attached to the axial skeleton, but loosely held in place by trunk muscles. Each has 3 borders and 3 angles, superior, inferior, and lateral. The shoulder girdle itself is very light, which allows the upper limbs to have a lot of movement. Each shoulder girdle attaches to the axial skeleton at one point called the sternoclavicular joint. And the loose attachment of the scapula allows it to slide back and forth against the thorax as muscles work, and the glenoid cavity is shallow. And the shoulder joint, while highly mobile, is poorly reinforced by ligaments, so for some people leads to higher chances of dislocation. So moving on to the bones of the upper limbs, we have the arm and the forearm, which can both be pictured in the image on the right. Just in general, I want to know that there are 30 separate bones that form the skeletal framework of each upper limb, including the arm, forearm, and hand. So the arm is formed by a single bone. So this is your humerus. It's a long bone. I talked about this a little earlier in the lecture. It, articulates with the lower bones here, the radius and the ulna, and the joint makes up the funny bone, right? It's humerus. Immediately inferior to the head is a slight constriction called the anatomical neck, which you can see illustrated here. Anterolateral, so front and to the outside to the head, are 2 bony projections separated by the intertubercle sulcus, the great tubercle, and the lesser tubercle, which can also be seen in the image at the top left. These are the sites of muscle attachment. So just distal to the tubercles is the surgical neck. It's named this because it's most frequently fractured in humans and requires surgical fixing. In the midpoint of the shaft is a roughened area called the deltoid tuberosity, and this is where the deltoid attaches. Nearby is the radial groove, which runs obliquely down the posterior aspect of the shaft. This groove marks the course of the radial nerve, which is very important in the upper limb. At the distal end of the humerus is the medial trochlea. It looks kind of like a pool. Trying to see if it's here. Yep, you can see it on this image at the bottom. In the lateral ball-like capitulum, which is outlined with a C from the anterior view. Both of these processes articulate with the bones of the forearm. So this is where you're going to connect to the ulna and the radius. Above the trochlea anteriorly is a depression called the coronoid fossa. And on the posterior surface, it's the olecranon fossa. These two depressions allow the corresponding processes of the ulna to move freely when the elbow is bent and extended. So the forearm, so moving on to the right side of this image, we have the two bones, the radius and the ulna. When the body is in anatomical position, the radius is the lateral bone. So if anybody knows how to find a radial pulse, it's thumb side, right? So that's where your radius is and your ulna is on the other side. When the hand is rotated so that the palms face backwards, the distal end of the radius crosses over and ends up medial to the ulna. So it twists over the ulna, which is pretty cool. Both proximally and distally, the radius and ulna articulate at small radioulnar joints, and the two bones are connected along their entire length by flexible intraosseous membrane. Both the ulna and radius have a styloid process at their distal end. The disc-shaped head of the radius also forms a joint with the capitulum of the humerus. Just below the head is the radial tuberosity, where the tendon of the bicep muscle attaches. So when the upper arm is in anatomical position, right, with your thumb facing out, palms facing forward, the ulna is the medial bone, so pinky side of the forearm, and on its proximal end are the anterior coronoid process and the posterior olecranon, which are separated by the trochlear notch. Together, these two processes grip the trochlea of the humerus in a grooved-like joint, so tongue and groove-like joint. So here's a skeletal depiction of the hand. So it's consisting of carpals, which is your wrist, metacarpals, your palm, and phalanges, your fingers. So there are 8 carpal bones of the wrist. I can tell you in practice, there's usually not an expectation, depending on the level of practice you're at, that you're gonna know exactly which or how to name all the bones in the wrist or which bone is fractured, etc. But well, that's something we'll work on. I'll see if I can find a good mnemonic for us to remember that. The carpals are bound together by ligaments that restrict movement between them, so they stay pretty tight. The palm of the head is your metacarpals. They're numbered 1 through 5, 1 being, from the thumb side of the hand rather, 2 towards the little finger. When the fist is clenched, the heads of the metacarpals become obvious, and those are your knuckles. The phalanges are the bones of the fingers, and each hand contains 14 phalanges. 3 in each finger, proximal, middle, and distal, except in the thumb that only has 2. Now let's talk about the pelvic girdle. It's formed by 2 coxal bones, commonly called the hip bones, and the sacrum. So the pelvic girdle versus the pelvis. The pelvic girdle is the coxal bones and the sacrum, and the pelvis is the coxal bones, the sacrum, and the coccyx. So unlike the shoulder girdle that we just talked about, which is light, highly mobile, the bones of the pelvis and the pelvic girdle are very large and heavy. They're attached very circularly at L5. And the reason why this is because this is the area of your body that's responsible for bearing weight. So it's important that it's strong, that it's secure. Every time we stood up, our hips would just be dislocated. It also acts to protect some important organs, including the reproductive organs, urinary bladder, and part of the large intestine. So each hip bone here, you can see, is the fusion of 3 bones, the ilium, the ischium, and the pubis. The ilium, which connects posteriorly with the sacrum at the SI joint is a large flaring bone that forms most of the hip bone. When you put your hands on your hips, they're resting over the alae, or wing-like portions of the ilia. The upper edge of the ala, the iliac crest, is an important anatomical landmark that is always kept in mind by those who are giving intramuscular injections. The iliac crest ends anteriorly to the anterior superior iliac spine and posteriorly to the posterior superior iliac spine. Another important structure is the great sciatic notch, which allows blood vessels and the large sciatic nerve to pass from the pelvis posteriorly into the thigh. So if you're giving injections in the butt, it should be given well away from this area to avoid nerve damage. The ischium is the sit-down bone. So it's called this because it forms the inferior part of the coxal bone, and the ischial tuberosity is a roughened area that receives body weight when you're sitting. The ischial spine is another important anatomical landmark, especially in pregnant women, because it narrows the outlet of the pelvis through which a baby must pass through during birth. The pubis is the most anterior and inferior part of the coxal bone. It's pretty low down there. The fusion of the rami of the pubis anteriorly and the ischium posteriorly forms a bar of bone enclosing the obturator foramen. This opening allows blood vessels and nerves to pass into the anterior part of the thigh. The pubic bones of each hip articulate anteriorly to form a cartilaginous joint, the pubic symphysis, which you can see in the top of this image. And you can tell it's cartilage because it appears as white. The ilium and ischium and pubis fuse at a deep socket called the acetabulum. And this is where the head of your femur goes, the head of your thigh bone goes. So you can see here it's comparing male and female pelvises. So before we discuss pelvic features, we want to acknowledge that the understanding of genders is evolving, but for the purposes of this discussion, we will refer to his and her pelvises. So the pelvis is divided into two regions. The false pelvis is superior to the true pelvis. So you can see this illustrated in these pictures. The true pelvis is surrounded by bone and lies inferior to the flaring parts of the ilia and the pelvic brim. The dimensions of a true pelvis for a woman who want to bear children are very important because it has to be large enough to allow a baby to come out. So the baby's head, which is the largest part, to pass during childbirth. The dimensions of the cavity, particularly the outlet and the inlet, are critical, and they're measured by your obstetrician. So your doctor will measure these and make sure that you're not going to split in half, which is obviously very extreme. But of course, individual pelvic structures vary, but there's some pretty consistent differences between male and female pelvises. So a female inlet is larger and more circular, which you can see in these pictures. The female pelvis is shallower and the bones are lighter and thinner. The ilia of the female pelvis flare more laterally, and that's why generally women will have curvier hips than men. The female sacrum is shorter and less curved. The female ischial spines are shorter and farther apart, making that outlet larger. And the female pubic arch is more rounded because the angle of the pubic arch is greater. So let's talk about the thigh and the lower leg. So the lower limbs carry our total body weight when we're standing up. So the bones by design are much thicker and stronger when you're comparing them to bones of the upper extremities. So the femur or the thigh bone, only bone in the thigh, heaviest, strongest, longest bone in the body. The proximal end of the ball-like head, a neck, and a greater trochanter and lesser trochanter. So you can see that on here. This head is what sits into the acetabulum of the pelvic girdle. The surgical neck of the femur, just like in the humerus, is a very common site of fracture, which is a bummer. Hip fractures are tough. The femur slants medially as it runs downward to join the leg bones, and this brings the knees in line with the body center of gravity. Distally on the femur, you can see in the picture, we have the lateral condyle, medial condyle, and those articulate with the tibia of the lower leg. Posterior condyles are separated by a deep intercondylar fossa, and anteriorly on the distal femur is the smooth patellar surface, and this is where your patella sits, this is where your kneecap sits. So the leg, connected along their length by intraosseous membrane, tibia and the fibula. You can see that intraosseous membrane going down the center. At the proximal end, the medial condyle and lateral condyle articulate with the distal end of the femur to form the knee joint. And the patellar ligament, which encloses the patella, which is a sesamoid bone, which we learned about, attaches to the tibial tuberosity. Distally, a process called the medial malleolus forms an inner bulge of the ankle, so you can feel that on your body. And the anterior surface of the tibia is a sharp ridge, the anterior border, and it's unprotected by muscles, which is why it can be felt beneath the skin. The fibula, much smaller than the tibia, lies laterally alongside the tibia, and forms a joint with it proximally and distally. It's thin and stick-like, so it has no part in forming the knee joint. Its distal end, the lateral malleolus, forms the outer part of the ankle, so you can also feel that on yourself. You can palpate that on yourself. So here we have the foot, and you can see the structure of the foot is very similar to the hand, being composed of tarsals, metatarsals, and phalanges. However, the function is much different. So the feet support your body weight and serve as a lever, so you can propel yourself forward in order to walk or run. The tarsus, forming the posterior part of the foot, is composed of 7 tarsal bones. Your body weight is carried mostly in your calcaneus, so that's your heel bone right there at the back, and the talus, which is lies right on top of it. The talus articulates with your tibia and allows you to do things like point your toes. So the 5 metatarsals are the sole of your feet, so kind of like the palm of your hand, and it has 14 phalanges to form the toe. So just like the hand, fingers 2 through 5, or toes 2 through 5 rather, have 3 phalanges, while the big toe only has 2. You can see on the image on the right, the arches of the foot. So the bones in the foot are arranged to form 3 strong arches. So 2 longitudinal arches, medial and lateral. Ligaments, which bind the foot together, and tendons of the foot muscles help to hold the bones firmly in the arch position, but will still allow a certain amount of give or springiness. So a lot of us, including myself, have flatter feet, so that's just a developmental or a structural issue in your foot. So with one exception, being the hyoid bone of the neck, every bone in the body forms a joint with at least one other bone. So joints are also called articulations. And it's just the site where 2 or more bones meet, with the function of holding the bones together securely and allowing the rigid skeleton to move. So they're classified 2 different ways. We have them classified functionally and structurally. Functionally, we have synarthroses, which are immovable joints, amphiarthroses, slightly movable, and diarthroses, freely movable. And structurally, And demonstrated in the image on the right, we have fibrous, generally immovable, cartilaginous, and then synovial, generally freely movable. So a little bit more about each of those joints as they are divided structurally. So we have the fibrous joints. They're united by fibrous tissue. An example would be the sutures in the skull. Gomphoses are peg and socket joints found where the teeth meet the facial bones. Syndesmoses can be found connecting the distal ends of the tibia and fibula. Cartilaginous, two varieties. Synchondroses, immovable, also called synarthrotic, and linked by hyaline cartilage, and symphyses, slightly movable, amphiarthrotic, linked by discs of fibrocartilage. Let's see if I can find an example of cartilaginous. So the intervertebral discs, so those discs that are between each of the vertebrae in the spinal column. And then synovial. So articulating bone ends are separated by a joint cavity containing synovial fluid. Four distinguishing features would be the articular cartilage, which is hyaline cartilage covering the ends of bones, forming the joint. Articular capsule. The joint surfaces are enclosed by a sleeve or layer of fibrous connective tissue, which is lined with a smooth synovial membrane, which is why these joints are called synovial joints. Joint cavity. The articular capsule encloses a cavity which contains the synovial fluid, which is lubricating and secreted by the synovial membrane, and then reinforcing ligaments. So a fibrous layer of capsule is usually reinforced by ligaments. So an example of this would be the knee is a synovial joint. So let's talk more about the general structure of a synovial joint. So like I said, the knee is a synovial joint. Basically, all of the joints in your limbs are synovial joints. So bursa and tendon sheaths are not strictly part of synovial joints, but often found closely associated with them. So essentially, bags of lubricant, they help cushion and act like ball bearings to reduce friction between adjacent structures during joint activity. Bursa means purses. They're flattened fibrous sacs, which you can see here demonstrated in the image, lined with synovial membrane and containing a thin film of synovial fluid. They're common where ligaments, muscles, skin, tendons, and bones rub together. And then the tendon sheath is essentially an elongated bursa that wraps completely around the tendon, subjected to friction. The book calls it like a bun around a hot dog. So let's talk about some synovial joints based on shape. So we have the plane joint, can be seen in figure A. The articular surfaces are essentially flat, and only short slipping or gliding movements are allowed. So these are non-axial movements. That is, they just glide back and forth. There's no rotation. So the intercarpal joints of the wrist are the best example of plane joints. So in figure B, we have a hinge joint. The cylindrical end of one bone fits into a trough-shaped surface of another bone. Angular movement is allowed in just one plane, like a door hinge. So your elbow joint, ankle joint, the joints between the phalanges of the fingers, and the hinge joints. They're classified as uniaxial, so they only allow movement naturally along one axis. Of course, if you break or dislocate something, it's going to have a lot more movement, but this is just natural intended movement is uniaxial. In C, we can see a pivot joint. The rounded end of the bone fits into a sleeve or ring of the bone and possibly ligaments. Because the rotating bone can turn only along its long axis, pivot joints are also uniaxial. To understand the motion of this type of joint, think about a basketball player pivoting around one foot that stands planted in one spot. The proximal radio-ulnar joint and the joint between the atlas and the dens of the axis are examples. So in D, we can see a condylar joint. It's kind of like a condylar means knuckle-like. The egg-shaped articular surface of one bone fits into an oval concavity in another. So both of these articular surfaces are oval. Condylar joints allow moving bone to travel from side to side, back and forth, but the bone cannot rotate its long axis. Movement across two axes, hence the joints are biaxial, as in a knuckle joint. In E, we can see a saddle joint. So each articular surface has both convex and concave areas, like a saddle for a horse. They're biaxial, allowing the same movement as condylar joints. And a good example is a carpometacarpal joint in the thumb, which is responsible for our opposable thumb. And then a ball and socket joint. So the spherical head of one bone fits into a concave socket of another. So it's just like it sounds, ball into a socket. It's multi-axial, allowing movement on all axes. So across the body, away from the body, forward, backward, including rotation. It's a synovial joint. It's freely moving. So like the shoulder and hip. So bone development before birth, and to adulthood. So all the way on the right, you can see an image of the fontanelles. So fibrous membranes connecting the cranial bones are called fontanelles. The rhythm of the baby's pulse can be felt in these soft spots. So this is a soft spot on a baby's head. The fontanelles allow the fetal skull to be compressed, which obviously we don't want to have after the baby's born, but when it's traveling through the birthing canal, we want it to be able to be compressed. Because it's flexible, it allows the infant's brain to grow rapidly during the latter part of pregnancy and in early infancy. So, and each of the fontanelles are supposed to fuse at certain times. You don't have to know that information, but just know that they're all pretty much ossified and fully fused by the age of 2. So in older adults, what often happens is, you can see in the image on the left, we have normal bone and osteoporotic bone. So there's just a lot more holes. It's not as dense. It's less structurally sound. And what happens is that it's a bone thinning disease that affects half of women over 65 and about 20% of men over age of 70. And we'll discuss a little bit more about why it affects women more than men. But also inactivity can make this happen. So that's why it's good to have weight-bearing activity as part of your physical fitness routine. That is what keeps your bones strong. So the ratio of bone formation to bone breakdown decreases. So your bone is breaking down faster than it can regenerate. Bones of the spine and the neck of the femur are especially susceptible. And vertebral collapse frequently results in a hunched over position, which is demonstrated on the right image. So you see woman age 40 standing upright, age 60, she slumps a little bit, age 70 even more slumped. And that's just the result of the bones of the spine becoming weaker. So estrogen plays a really huge role in this process for women. So estrogen in general helps to maintain health, but also the normal density of a woman's skeleton. And an estrogen deficiency just naturally occurs in women when menopause occurs. And it's strongly implicated as the cause for osteoporosis. So of course other factors can contribute, like poor diet intake of calcium and protein, lack of vitamin D, smoking, insufficient weight-bearing exercise. Many older people will think that being sedentary is like saving their strength, saving their energy, but a really good way to explain it to patients and remember it yourself is that a body in motion stays in motion. So it's really important for people to move and bear weight on their bones, or else their bones will just continue to get weaker. Additionally, to osteoporosis, we'll have osteoarthritis. So this is just like a degenerative use, quote unquote, wearing out of your joints from weight-bearing activities, especially in your weight-bearing joints. The degenerative changes will lead to complaints like my bones are stiff, or my joints are stiff. So some of this stuff is bound to happen, but there are definitely ways to prevent the severity and the rate of acceleration of these older adult changes to bone and joint structures. So our critical thinking stopping point, let's reflect back on what we've learned, what we've read. So bone x-rays are sometimes used to determine whether a person has reached his or her final height. So what do you think clinicians are checking out on an x-ray that will help them determine, like, yep, you're done growing? So you'll have to harken back to maybe skeletal development, what allows for bone growth, etc. And we'll talk about this question in class. Any questions, comments, or concerns, please feel free to let me know.